great symposium at lunchtime. It's about real cases and trial outcomes, a new standard in SFA interventions, sponsored by BSc. And we also have to thank you, BSc, for doing this. And with my two colleagues here, a third one is joining us soon. I would like to invite you to listen and do this data and take home for your practice a lot out from this data. So I want to start with Professor Steiner, who is the head of the Division of Angiology at the General Hospital in Vienna. She will give us insights from the best SFA RCT cases. Please, Sabine.
Yeah, thank you very much, and I'm sorry for showing up late. I came from a different symposium, and I'm actually filling in because I'm probably the only person from Münster present on this Congress, and I've implanted a few of these stents myself when I was there, so I guess you'll have to bear with me for a moment. So all these slides are not mine, I'm just presenting them to you. So I would like to present to you the All-Comers Registry of Münster. The rationale behind this kind of study is that we have, as Professor Tepe has already shown, a lot of very high quality RCTs, but as we've heard in the discussion before, those are not really real world settings in which these kinds of stents are implanted. So as in all registries, the goal of this kind of study is to be able to actually generate data that can be extrapolated to your daily practice with all the variables that you will encounter in your own practice. Of course, it's not as scientifically sound, but I think it's nonetheless very interesting. So what we did in Münster was to assess the performance of the Illuvia in a setting where we would actually use it, and that would be long lesions, yeah, and complex lesions. And so included in this registry are patients treated from 2016 to 2018, and the primary outcome was primary patency. So the criteria for actually using the Illuvia was, as we've mentioned before, recoil and flow limiting dissections after PTA. And that will come into play in very long occlusions, as we've all seen in the session a couple of times. In these kinds of cases where you have a lot of calcium, for example, and you don't expect enough drug uptake because of the calcium, in cases where you have a chronic total occlusion that's even long, you would actually use it. So you know these kinds of slides. This is the all-comer cohort from Münster with 130 patients. Actually also quite long lesions, as you would expect, high rate of CLI patients and high rate of calcified arteries. So this is definitely on the right side of the slides you've seen before, and this is a typical patient. You have a very long occlusion until the usual spot down there, hang on, there, yeah. And this is a case that's actually perfect for a drug-eluting stent because it's just, you don't expect any other device to perform as well on the long term. Another example is when you are crossing, for example, a shorter occlusion, and you're performing a vessel preparation, yeah, before you decide what kind of technology you want to use, and you see this, yeah, recoil. This is an immediate recoil. Sometimes it happens later, but in this kind of setting, I don't think it's enough to use a DCB or a bare metal stent. This is actually a very nice case where you would actually implant a DES. This is after another dilatation. Here you see dissections and so on. So this is not going to stay open, as you know. Yeah. That's another case with a long occlusion from the femoral bifurcation until basically the distal SFA, and after doing a plain old balloon angioplasty and with a actually quite okay result and DCB, you get, oops, hang on. You get this kind of result, yeah? You see, it's actually a nice flow, but you can appreciate, I think, the dissection you have here, and this is basically the re-entry point. Professor Steiner was alluding to this, yeah? You have a distal re-entry point, and this will, in the long run, get you into trouble, so that's always a very nice case for stenting, I think. So the key lesson in these kinds of very long occlusions, you will have to use a DES actually, because if you don't use a scaffold, you will not have the mechanical stability, and if you don't use a scaffold with without the drug, you will get instant restenosis, as we've seen a couple of times now. Yeah. What about calcium? I mean, this is even more difficult because you will have the problem of drug uptake, and you will also have the problem of impaired expansion. Yeah? So in that case, again, we decided for upfront stenting, or the colleague decided for upfront stenting of this calcified occlusion here, and basically after that kind of result, do a PTA, yeah, to expand the drug-eluting stent, because I don't know if you can appreciate it, but there's you have a lot of stenoses here in the proximal section of the SFA. In those kinds of cases, it's always good to use short balloons to exert more force in the segments that are very heavily calcified and stenosed. And I think, again, a DES is a very good device to be used here, because you really have a lower rate of restenosis through this kind of scaffold. If we put this into perspective with the other studies that we've just seen, you basically know these kinds of slides. Yeah, you basically see that if you use an alluvia in your patients with these long kinds of occlusions, almost 20 centimeters, you will still get very nice primary patency rates at 1 year and 2 years, and if you fully cover the lesion with a DES, you will even get higher rates. So the number above that you see here is from patients being treated with an alluvia, but also, for example, DCB in no stenting zones, for example. And if you're able to actually cover the whole lesion with a DES, you will get even better results. As Professor Tepe already showed you, we're using that kind of device in very long lesions with a high success rate. So I guess it's sort of like hammering this into you, yeah. But it's I think it's still nonetheless very interesting if you compare it to other devices. Yeah, and I think we've mentioned the aneurysms. So this is from our 5-year data. We did see something that we didn't really call aneurysms in the study. We really called it halo sign, because we really didn't know whether it was a true aneurysm or not. But what we could actually see in about 20% of the patients is an expansion of the arterial wall around the alluvia stent. It wasn't perfused, but it actually did look like an aneurysm. And if you look at the patency rates of patients affected by this kind of phenomenon, you actually see that they have statistically significantly higher patency rates, which is very interesting. I think we can discuss about this later, probably. Yeah, I just want to close with a few long-term data in the end, but I think what you've seen all is that you can really successfully treat your patients, downgrade their disease, and have, and that's important, I think, sustained high patency rates of like about 80%, which is actually almost like a bypass here, yeah, with endovascular means. So that's, I think, pretty amazing. All right, so I think I'll conclude. Eluvia is a very nice bailout strategy in case of dissection and recoil with very nice patency rates. And I think looking at the 5-year retrospective data of a registry, I'm really looking forward to the data from the RCTs, but I think you get very nice bypass-like results with this kind of device. Thank you very much.
Yes, thank you. Are there any questions from the audience? If not, I would like to ask all of you one question. What data are still missing after what we have heard so far? Real-world data comparing TS, TCP versus bare metal stenting, TS compared to TCP with bailout stenting. So what is still missing to guide our daily practice to get a treatment algorithm? Or can you already give me a treatment algorithm?
So who is going first? I personally, everybody just talks about the need of vessel prep, but there are no data. So I don't know if it's, yes, but it could be something that also the postulatation is done much more precisely and so on. Is there a better uptake? At least there is a PAD3 study with shockwave, and the patency rate does not differ. So for me, yeah, that would be, and also for vessel prep, which is the best device? Is there any difference between atherectomy, like litho, something like that? So that would be something, but a study would be very difficult to do. But that's still something I don't know.
Yeah, I can't agree more. I think the problem is we have this large heterogeneity of SFA lesions, and you can't just do a study comparing directional atherectomy with orbital atherectomy because you just use it for different lesions. So it's more about the general concept. How much does it has an impact with respect how much drug transfer we need? Will there ever be an option to measure drug transfer in humans, or can we just transfer preclinical data from swine models, whatever, into humans, which I think we can't? How much role does it really play how deep our vessel injury is before we do the drug transfer? So I think that's, for example, for me, a big question with very aggressive ballooning. If you then have vessel injury into the adventitia, would that make a difference? Maybe even cause more aneurysmatic changes, which we do see, especially I think after aggressive predilatation and drug-coated balloons, as you've mentioned before. So I don't really see clinical trials, to be honest, to answer these questions. I think we need extremely good registry data with core lab adjudication from angiograms. I think this is a prerequisite because we know what investigators are reporting is a little bit what they wish for, not really what is there. Maybe IVUS and other imaging modalities which will come up in the future can help us here to see how much that really has an impact on our outcomes. I think that's what I'm looking for.
Okay, speaking less, it's probably a little bit hard, but I think one question that we're always asking ourselves also is post-interventional medication. I think everybody has their own like sort of little regimen. Of course, there's Compass and Voyager and so on, but I think they don't really apply to every single patient in my view. And I think what's also missing is data on Profunda. Yeah, that's it's totally not seen in many studies, so that would be interesting to me, actually.
Thank you very much for your answers. There is one question here in the app. In heavily calcified CTOs, and I also wanted to ask that before, so I guess it's for you, Dr. Dassela. After using shockwave IVL, does drug uptake from TCP or DS increases or decreases?
I don't know. I don't think that, as you know, we've pointed out, it's hard to measure the drug uptake in this kind of setting. I think that there is not enough published data on whether that really is affected. We know we have RCTs that are comparing IVL to PTA, and it's only looking at dissection, post PTA dissections and procedural data. But as far as I know, it doesn't really look into whether the DCB group, the DCB after vessel prep with IVL had higher patency rates. I don't think it had, actually. No?
Yeah.
Just my comment, I think if you have severe calcification, the question is how much role plays neointimal hyperplasia. And what we do with drug-eluting technologies is inhibiting this inflammatory response and neointimal hyperplasia. So if your mechanism of disease progression is anyway a different mechanism, I think it's very hard to affect that with a modality that's not really made for it. So I think it's really hard to go for this calcification and drug elution.
Thank you very much, Marianne, for the kind introduction. Yeah, perfect. So we had a little bit of switch in the program. We won't start with the Münster cases, but with some insight from Best SFA, which is a randomized controlled trial involving various German centers I was overseeing while I was still working in Leipzig. But as Marianne just mentioned, I moved to Austria just recently. These are my disclosures. Also some important information, of course, that these are some case studies which might not be appropriate for every patient or case. And now let's focus on Best SFA. Best SFA is a clinical trial we published a few months ago in Czech Interventions. And I think what's interesting about it, it's actually encouraging vessel prep before we go for a drug-eluting technology. So what we did here, that we randomized patients to a primary stent avoiding strategy, so mostly using paclitaxel-coated balloons, versus a primary DES, so drug-eluting stent strategy using the Eluvia stent. And here the operators were really encouraged to use adjunctive vessel prep in complex lesions, and this was at the decision of the operators. So I think it's we all do agree that drug-coated balloons work very well in easy lesions, so task A and B lesions. Also for in-stent restenosis, we do see excellent clinical outcome, and we still prefer them, of course, for no stent zones. Also, I think we become more liberal with respect to these decisions also to stent, for example, in the popliteal or common femoral. Drug-eluting stents, I think, for many of us are the first choice for flow-limiting dissections or in case of relevant residual stenosis, above 30% after predilatation. But the decision is also difficult. Does it depend on lesion length? How does that play into this decision-making? What about CTOs? Should we prefer stenting over DCB in total occlusions? And of course, what's the outcome here in calcified lesions? So that were some questions we tried to address in this clinical trial. Just as a reminder, we do have some very good analysis with respect of predictors of DCB failure from the IMPACT clinical trial program. And what's interesting when we look at these predictors within regression models, most of the predictors of restenosis or loss of patency or reintervention are actually under our control when we do the index intervention. And what's popping up again and again is residual stenosis above 30%. So that's a relevant predictor after DCB use for the loss of primary patency, for restenosis, and also for reintervention. So this is clearly a failure boundary, not a target we should stay below, but I think we have to stay below. Just a reminder now on our best SFA cohort. It's a pilot study, so it's not powered for our clinical outcomes, but we randomized 120 patients in various centers, and these were complex lesions. The minimum lesion length was 10 centimeters, but actually we had then over 2/3 of our population had above 15 centimeter long lesions with an average lesion length of around 18 centimeters. Most patients suffered from severe claudication, and we had about 2/3 of moderate or severe calcification when adjudicated by the core lab. And what's also interesting, it's actually a CTO trial. I don't know many trials who included 80% chronic total occlusions. And this is also highlighted that we needed a re-entry device in about 16% of lesions. And we also had some retrograde access as an option available. When we look at the procedural outcomes for each strategy by core lab adjudication, and just as a reminder, in the stent avoiding group, we used additional lesion prep beyond plain old balloon angioplasty in about 70% of cases, and this was about 50% in the stent preferred group. And this adjunct lesion prep could comprise various devices. So scoring balloons were an option, but also directional and orbital or rotational atherectomy. Also mechanical thrombectomy using the Rotarex device was quite common. So what we can highlight here, we still see, despite these quite extensive lesion prep, relevant residual stenosis, and the mean diameter stenosis post-procedure was around 30% in the stent avoiding group and clearly less in the stent preferred group with 23%. Dissections, post-study device, and in the final angiogram, also here, as expected, I would say, so we see more dissections in the stent avoiding group and less dissections, so 80% no dissection in the stent preferred group. But what I really want to highlight, despite this extensive lesion prep, residual stenosis is still common when you treat long CTOs. In about 45% of cases, we see a residual stenosis above 30% in the DCB group, and almost every fourth case, even in the Eluvia group, showed that. Residual stenosis above 50% was rare and not seen in the stenting group. And just also as a reminder, well, it was a stent avoiding group, but we didn't really achieve that in that many cases. Falling quite nicely with other clinical trials like the IMPACT DCB program or the COMPARE study comparing two drug-coated balloons, in long lesions around 20 to 30 centimeters, you end up stenting anyway about half of the lesions, even if you go for a DCB preferred strategy. But this session is called cases. So I want to show you a case of a patient that was actually randomized to the stent avoiding group within the best SFA study. It's a 70-year-old male, Rutherford 3, and these are the core lab adjudicated lesion characteristics. So reference vessel diameter was assessed as 4.8 millimeters, target lesion length 26 centimeters, and most of it was a CTO. Calcification, I wouldn't see that much in the angiogram, but as according to the core lab, was quite moderate calcification there. For lesion crossing here, I finally used a BPAC catheter for re-entry because it was not really that easy from antegrade, which really allows you to puncture here the let's say the best spots so that you don't have to dissect further down. And then lesion prep here was done with a scoring balloon and standard predilatations, a sizing 1:1, so using a 5 millimeter diameter balloon for both the standard angioplasty as well as the scoring balloon. After predilatation, you can appreciate quite a severe dissection here in the proximal entry zone. And then the paclitaxel drug transfer was performed using 3 drug-coated balloons, 3 Impact Pacific, 5 by 120 distally, and then going up with the 6 more proximally. So according to core lab, we actually treated quite a longer distance. Maybe you remember it was a 26 centimeter long lesion, but as you often do with the DCB treatment, it ended up the treated lesion length of about 32 centimeters. After the DCB treatment, there was still this dissection proximally and some residual stenosis distally. So bailout stenting in the proximal part with an epic 7/40 and Bos dilatation over a prolonged time interval distally. And so these were the final angiograms, which are really, I think, quite good. And interestingly, that was the residual stenosis according to the core lab. The patient came to his scheduled follow-up visits, and after 2 years, he reported actually recurrent symptoms for about 1 month. And the TLR was planned because the patient was really limited by claudication again. So an 8 French crossover sheath was brought in. As the onset of the symptoms was pretty acute, we expected fresh thrombus also in the lesion and would go for a mechanical thrombectomy using the Rotarex device. We tend now to use much more 8 French Rotarex compared to 6 French, but that's something we can definitely discuss about. What you often have then with the Rotarex device is that especially you have this collapse in the stent area, and this also happened in this case, so that we needed some gentle predilatation here. And just maybe as a side note, I find it interesting, because we talked about in the last few years so much about the halo phenomenon, and just as a reminder, of course, this is a bare metal stent. We saw quite some impressive halo phenomenon at the ultrasound scan before the reintervention. Of course, nobody really knows what the clinical impact here is. So the patient was treated with Rotarex and then DCB for this instant restenosis proximally, and also DCB distally in the re-entry zone of the original occlusion. And in the final angiogram, actually the result is quite nice, but you still see a little bit a moderate restenosis left in the proximal stent. So the idea is that really what made this SFA to come down was an instant restenosis in this bare metal stent implanted as bailout stenting. The patient is now followed for 4 years, and there are no recurrent symptoms since this TLR. So some lessons and questions from this case. Bailout stenting, well, I think it's necessary, but we also do see instant restenosis, of course, after short stents for bailout stenting. This is not immune from restenosis. Of course, there's underlying disease and neointimal hyperplasia. Dissection is important, front and back are covered. Would IVUS help? That's something we can discuss. And maybe we should even use a DES for bailout stenting. An alluvia case, very similar. It's a 69-year-old male, Rutherford category 3. The core lab adjudicated the vessels a bit larger, target lesion length 20 centimeters, almost all as CTO, clearly less calcification. The patient was randomized to do a drug-eluting stent strategy. Lesion prep was here 5/120, just plain old balloon angioplasty. As the vessel really opened nicely, there was then direct stenting, covering the lesions with 2 alluvia 6/120 and Bos dilatation. According to the core lab, the treated lesion length was not that much longer than the original lesion. What I found interesting, they found a residual stenosis of 26%, which I wouldn't have seen in the angiogram, but maybe it was this small, segment here, because this is an angiographic follow-up 7 months after the intervention during a contralateral intervention. The patient had his follow-up after 2 years, no instant restenosis, duplex ultrasound, no halo phenomenon, and the patient is now also symptom-free for 4 years and needed no reintervention. So these were our freedom from clinically driven TLR curves at 24 months for the best SFA study. We did not see a statistically significant difference, but quite a good freedom from TLR for these complex lesions of around 78% freedom from TLR in the stent avoiding and 83% freedom from TLR in the stent preferred group. Also, interestingly, in those patients who received Eluvia drug-eluting stent in lesions below 15 centimeters, we had a 100% patency rate. And I mean, this just indicates that especially in these, let's say, moderate long lesions, you really have excellent results with drug-eluting stenting using the Eluvia stent. Some rules for Eluvia DS deployment. I think vessel prep is here also essential to optimize lumen to reference vessel diameter. Of course, assess result and decide the landing zones. You should go from healthy to healthy. Deploy the stent slowly. We now have also the 15 centimeter Eluvia stent available, which might also important to really do a good deployment. Post-dilatation is necessary. You should never leave residual stenosis above 30%. And I think good preparation is better than rescue post-dilatation. Check runoff. Of course, here you could see bystander stenosis, and it's the question how you're going to treat that. The best SFA study, as I mentioned, was published in Czech Interventions, and we got a very interesting and a very nice editorial for the study. And Pionde Tsokai started this editorial, we don't be afraid to give up the good to go for the great. And I think what he highlighted in this editorial, that we actually do see excellent results with the drug-eluting stents, especially when we have no residual stenosis, so when we had a very good lesion prep. Thank you very much.
Yes, thank you, Sabine. I would also encourage the audience to write their questions into the app or to come to the microphone and ask them just here in person. Please, there's the first one.
I just wanted to know, so what burr size you are using in SFA?
We couldn't hear you, sorry for that. Can you repeat
so
it?
So what size of burr you are using in the Rotarex for the SFA intra-stent preparation?
Size of, so this one, like the case I showed you, was an 8 French Rotarex. I mean, you could argue 6 French would be safer. We changed a little bit our strategy over the last years to go more for the 8 French because just the intensity of thrombus removal is clearly much higher, especially for instant restenosis. If you have from your medical history clear signs and from your wire passage, of course, as well, clear signs of a lot of fresh thrombotic material. The centrifugational force is just much higher of the 8 French Rotarex, and what we see is we don't need so much additional short-term local lysis then after that. So this was an 8 French device.
Yeah, there's another question. Please come over to the microphone. The microphone is on, just speak into it.
Yeah, I just want to know in the first example which you have shown, post pre-dilatation, there was a significant dissection, I guess, and still I think you've chosen to go ahead with a DCB. So is it the usual practice, or in a case where there is a post-dilatation or a pre-dilatation, I mean to say, if there is a dissection, you avoid DCB? What's your take on this? Because what I believe is that if there is already an intimal flap, the dissipation of the DCP drug will not be a circumferential because of the intimal flap. So what's your take on that?
I mean, we have to remember that was within a randomized clinical study. So the patient after the wire passage was actually randomized to one of the 2 strategies. And so in a way, this patient was, it was a male, he was randomized to drug-coated balloon strategy. And of course, you can say this is a kind of an artificial decision-making because it's an RCT. You're totally right. I think pre-dilatation is this first step where you decide then your next strategy steps. And I think what we have changed over the last few years, that you do a more aggressive pre-dilatation, to do it in a one-to-one sizing, because then it gives you a better impression how much dissection you have and how much residual stenosis you have. I still think we achieved really a good result with the DCB strategy in this case. After predilatation, I think many of us would also lean to stent the distal re-entry zone. And definitely, and this is what you most of the time you do stent, the proximal and the distal entry zones. So, yeah, that would be my strategy.
Thank you.
There's another question in the back.
Yes. What do you think is the role of anticoagulants for this kind of patient? If yes, then how many and for how long? And for whether for the one group of patient or both group of patients?
Yeah, I mean, first of all, this, as you know, it's a difficult question, of course, how to anticoagulate these patients. It also depends a little bit on your local reimbursement situation, which can differ in each country. We still stick a lot with dual antiplatelet therapy for a limited time period after drug-eluting technologies in the SFA. But in patients like that, claudicants, with a good runoff, with a good result after your intervention, I would also feel comfortable to go with a Voyager scheme, so to go with an antiplatelet and low-dose rivaroxaban. I think both options are good. Both patients were relatively young, they were around 70, so the bleeding risk is relatively low. I would feel pretty comfortable to go here for this Voyager scheme on a long term because we know it reduces major adverse limb events and it also reduces major adverse cardiovascular events. But I think it's also fine if you say for 1 to 3 months I prefer a dual antiplatelet strategy, not to risk any acute stent thrombosis or acute thrombosis at all.
I have a question for you, Sabine. I mean, you were showing the really good result of drug-eluting stent in these long complex lesions. And if we do the TCB strategy and we need to use a Balard stent, should we then right away switch from bare metal to a TES as a Balard stent? Would it be the conclusion out of this study? Because this is my feeling after this data right now.
I mean, these two cases were, I think, perfect, and this is why I've chosen them, because they still had a stump at the SFA. And it's really nice when there's a good stump, because you know with your stenting, if you have to stent the origin, you won't affect the profunder. If it's a flush occlusion, I think the decision is much more difficult. It often means that you really have to bring up your stent into the common femoral artery, and while we know this won't affect patency, I think it massively affects the patients who do have a patency failure. So the patency failure patients really have a worse outcome if also the stent is within the profunder. It's then they often present with acute limb ischemia instead of claudication. So that is a little bit a scenario where you try to, at least I in younger patients, claudicants, where I expect that they will go on with these stents for decades, not for some years. I try to avoid that I bring up the proximal landing zone of the stent into the common femoral, and I really try a lot of things to avoid that. Having said that, yes, I think we move now more back to if there is dissection, if there is residual stenosis after intense predilatation, we go for a primary stenting strategy with a drug-eluting stent.
Yeah, thank you very much, Marianne, for this introduction. And I'm going to give you an insight in the sports trial, a randomized trial. This was also a trial with long lesions, TAS C and D lesions, and also the Eluvia stent in that trial. Now, most prospective randomized DCB studies are IDE trials, and the problem is that they have lesion lengths which are short only, TAS A and B, and independent trials are available, but sometimes it's limited to 1 and 2 years for the primary endpoint, and the problem is that there are no randomized data really available for long lesions, and we don't really know what to use, and there's also very often no call-up, so we don't have data for a really decision what device to go for. Now, I'd like to start with some data with the Eluvia stent. There was the eminent trial and the imperial trial. These were trials which were prospective and randomized to a control group. The first one to a bare metal stent, the second one to the silver PTX stent. And as you see over here, both studies showed a superiority according the patency according to the control group, both bare metal stent and the silver PTX at 1 year. Now, how does this really get into the landscape of all the other trials and also the sports trial? You see up here we have the patency rates here of those trials, but these were really first trials and the lesion length was very short. So with the longer lesions over here, we have other trials, but what you can see already here is that the patency is still quite high. So sports is even longer. Sports is longer than 23 centimeters of lesion length, which we were looking into here. So the complexity in that study increased a lot. So patency rate, as I said over here in the current trials, is very nice at 1 year. So the sports trial was a prospective randomized trial, and we really compared 3 different groups. One was the DCB group, drug-coated balloon, the sequin please balloon of B. Brown, a balloon which we know that it has good outcomes in 2-year follow-up data. Then in the bare metal stent group, almost every stent was allowed, and we also used a lot of superior and biomimic stents. And then as a drug-eluting stent, we used the Olivia stent. And the primary endpoint was an angiographic endpoint, so all patients received an angiography at 1 year. Diameter stenosis was measured, and we had 2 hypotheses. One was superiority of the drug-eluting stent over bare metal stent, and the second one was non-inferiority of the DCB versus the bare metal stent. So the lesion length at least 13 centimeters and a good runoff. So you have seen that slide already, and you have seen what is known. So DCB is good for short lesions, and DS might be considered for slow flow-limiting dissection and residual stenosis. But for C and D lesions, we don't really know if a bare metal stent is good. There are some data there, but no control group, DS or DCB. And this was investigated in this prospective randomized trial. So lesion lengths almost 23 centimeters, Rutherford class 2 to 4, a very high calcification grade, and a lot of total occlusions. You've also seen this slide, and now we added the sports arm. So you see that with increasing lesion lengths, there are more stents used. And of course, if you have really long lesions, more stents are used, more spot stenting is used. In sports, it was 58% in the DCB arm. So over here, we have now the primary endpoint, diameter stenosis, collab adjudicated. So in the bare nitinol stent group, it was 60%. In the DCB plus spot stenting over 50%, as I mentioned, 54%, and then Eluvia 25%. And on the right-hand side, you see the both hypotheses which were tested. So first one here, DCB non-inferior to bare nitinol stents, so this is true, and then the Olivia drug-eluting stent superior to the bare nitinol stent, also true over here. So we also looked at the so-called late lumen loss. That's something which you can measure in the angiogram. So it was 2 millimeters in the bare nitinol stent. In DCB, it was half, 1.1 millimeter, and only 0.4 millimeter in the Eluvia stent. Secondary endpoints seen over here, Eluvia stent, drug-eluting stent, DCB, and bare metal stents over here. So you see one case which we used, were randomized to the bare nitinol stent, occlusion from over here to here, but high-grade stenosis down here. So pre-dilatation was done in the whole area, but I have the image of the total occlusion here. This was after pre-dilatation of the occlusion. And then at the end, everything was pre-dilated, and 2 long stents were used, 15 centimeter stents, and the stent was from over here to, you see, down here, and a really good antegrade flow. The patient was doing fine. And then the patient came back after 6 months with ultrasound already, and this is an angiogram which was done prior to the intervention. So you see a total occlusion here. This is something which, of course, is not seen in every bare stent, and especially not a total occlusion with total thrombosis, which we have seen here. So this was acutely thrombosed. And you see the thrombus formation. So we aspirated this, and then we had to do additional lysis, and afterwards DCB treatment was done. So what we very often do in in-stent restenosis, we do double DCB in order to enhance the dose. We've done this in this case too, and afterwards the outcome was fine, but we had to do a re-intervention. So again, just seeing uncoated stents, non-drug-eluting stents, with longer lesions. You see the sports study is over here. You see with longer lesions, what you see over here is that the patency rate goes down. So with the Alluvia stent, the drug-eluting stent, we have a really good patency even in those complicated long lesions. So again, from the study over here, this patient was randomized on the left-hand side to Alluvia. Right-hand side was later treated with the DCB, not within the study because, of course, you can enroll the patient only once. But on the left-hand side within Alluvia stent, you see that this was the outflow, and we used the Alluvia stents, and was quite nice result. And then at 1 year, we have done the follow-up angiogram. You see on the left-hand side, very nice result after the Alluvia stent, no neotomal formation. On the right-hand side, it's really looking like a DCB result with some spot stenting. Yes, that's like it is. So very important is if we have to have a stent in place, and that's something we have to take into account, especially in longer lesions, that the proliferation takes longer, neotomal proliferation, and therefore, of course, also the drug should be there for a longer period of time. So with the DCB, of course, the drug is embedded in the vessel wall, and of course it's there, but not as long. This is with the silver PTX stent, and with the Alluvia, you have the drug there for a much longer period of time. That might be also the reason. So in conclusion, a sports randomized trial provides new data on primary strategy in task C and D lesions. The Alluvia drug-eluting stent was superior to the operator best choice bare stenting with full lesion coverage, and the DCB plus or minus bailout spot stenting strategy was non-inferior to a full lesion bare stenting. Long bare stent restenosis remains a problem, as I've seen shown over here, and TLRs are costly. And what we're doing right now, we do further analysis on the core lab adjudicated failure modes for each strategy, especially because we were quite astonished that the DCB group had quite a lot of TLRs and failures, and we want to learn why this happened. Thank you very much.
Thank you very much, Gunnar. Just, I guess you can have a seat, and we can then use the microphone. There is already one question here on the app. Can we deploy 2 Alluvia TAS up to 150 millimeter to cover up to 320 millimeter SFA stenotic lesion? How much is overlapping distance between the 2 stents?
Yeah, so that's something we will also look into here. So we try to to overlap only like 1 or 2 centimeters. But within that study, of course, we use a lot of stents, and because the stents are available in certain lengths, only 12 centimeters, we started with 15 centimeters, there is quite some overlap. I don't see that there is an issue, but again, in the core lab analysis we are doing, we will look into this and see if there is an issue both in the bare stent group and also in the Alluvia group, if there's something to learn with overlap. We don't know.
Okay. Are there any questions from the audience? Please, go.
So in the one of the case example you have shown where there was a stent occlusion, you use a double DCB to augment the dose of the drug in that region. So do you have some protocol for this, or you have some data to support the use of double DCB for a stent occlusion? I mean, it may have a superior patency as compared to a single DCB.
Yeah, and that's a good question. So you know that, of course, that's done right now, but there's still was the discussion of safety of paclitaxel in the room some years ago. But nevertheless, I do think that some patients really desire a higher dose of drug. And not one dose is fine for every lesion. So what we've seen in another study we've done at our institution is that DCB does good in in-stent restenosis, but there is a catch-up, or might be a catch-up at 2 to 3 years. So it's not any better than bare balloons. Very beginning, yes, but long-term, no. Also in that study, every patient who came back with restenosis was giving a double dose, so 2 DCBs at the same location, and at least in that study, no TLR occurred anymore. So what we're doing right now, as a standard of practice, every in-stent restenosis, double dose. And I don't see any issue of that. Of course, there are no scientific data, but I think that's might be a way to go.
Thank you.
There's another question, please.
Congratulations, Gunnar. Good to see the data finally published. Was there any problems with aneurysms in the Alluvia group?
No. Actually, we had one problem in the DCB group where one physician dilated to rupture, actually, pre-dilated, and then a DCB was used. And after the DCB, we had aneurysms in the DCB group, actually. But we have seen that, and they stayed like this, and they didn't grow. We had this in the DCB group, but not in the Alluvia group.
Because you said you use 2 doses of paclitaxel, would you go for then maybe combining a paclitaxel DCB with a Limus DCB in the future?
Yeah, it's a good question. I actually
yes
tried
or no?
that.
Yes or no?
I tried this actually, but I don't know if it's really a good idea. I just because of course, yes, if paclitaxel does not work, that's a good idea. Might be a good, but I don't know. I think because you need a lot of patience, a lot of long follow-up in order to answer the question. But I had the idea, but no answer.
I have one question. You know, I think this case you have been showing us with treatment on both legs and both sides was very interesting. You see the outcome from the Alluvia stent, and then you see the TCP arm with bailout stent. You know, where you have already atherosclerotic stenosis, for sure not high grade, but you can imagine that this patient at some point might have issues, and you have to re-intervene. So I think, you know, with regard to what kind of lesions should we treat then with this full TES strategy?
Yeah, that's a very good question. So first of all, I think I try to learn more why the DCB, at least in those long lesions, did not work as I expected. I think this DCB itself, it's a good one. But something might have happened. So what we don't know is, did we stent enough? We just know how much patients received stents, but not how much was really covered. Did we cover everything? So right now, the week before, I did a patient who was young really, and after pre-dilatation, I saw a lot of dissections, and I just went right away with an Illuvia stent because I thought, okay, if I use a DCB, anyhow, I will end up with almost stenting everything, and I don't know what I really should not stent in that case. So that would be something what I would do, and at least from the 1-year data, I know the outcome will most likely be great.
Yeah. Do you think? Do you think that IVUS might help us in this decision? Sorry. So we have both the same thinking.
Yeah, I don't know. The problem of the total occlusions is we have to had this discussion this morning also. Very often I go subintimal. So and with re-entry, so how does IVUS? What is the sizing of a stent or in a subintimal place? So and how would this help? I don't know.
Please.
I think it might help determining whether there's a flow-limiting dissection, for example, that might affect long-term results. But yeah, I agree, it's tough, but you just have one plain view, right, of the DSA?
In the DCB group, yes, it might have been. With IVUS, we would have been better. I don't know.
Just one comment to the flow-limiting dissection. If I suspect a flow-limiting dissection in the angiogram, I'm sure the IVUS will tell me it's flow-limiting. Don't you think so?
Yeah, well, I think that basically what I think we all have, have had these kind of cases where you think the angiogram looks okay, but you have a restenosis or like a reocclusion very early on, and I guess it must be a flow-limiting dissection. It didn't look like it in the DSA. I don't know, but I mean, at least it's a dissection, right?
Or it's recoil, I mean.
But you would see the recoil, I guess, in the DSA.
If you wait long enough.
Yeah, if you wait long enough.
If you wait long enough, yeah.
But dissections, anyhow, with the DCB, which are not severe and flow-limiting, are, at least in my understanding, not too bad because there is more uptake of the drug and you might have even a positive remodeling. So I've seen dissections right after the intervention, and then I did a follow-up angiogram at 6 months, it's just gone. Yeah. So not every dissection has to be stented. The problem really is I don't really know when do we have to stent and when can we leave things alone. So the indication for stenting is something which I think is not clearly understood.
Gunnar, there's a final question here on the app for you. For how many years drug is released from Illuvia in the FEMPOP segment? Does it prevent neointimal hypoplasia, inflammation and atherothrombotic events? So for how many years drug is released from the Illuvia stent?
Yeah, not so long, not for so many years. You have seen that it diminishes after a certain period of time. So after like that 1 year, there's no release anymore. And what we hope for is that then there's endothelialization and the stent itself is doing fine.
Yeah, we are at the end of this session. I think I want to just thank you all for this great presentations and the lively discussion, and also the audience for taking part into that. We have, in the meantime, really good evidence of drug-eluting technology, TCP and also TES, especially for the Illuvia scaffold. And I think with all the, especially with the more complexity of our patients and lesions in our patients, I think what you have shown with task A and P lesions, TCP treatment as a first treatment approach, and C and T lesions with a TES approach could really help us in our daily practice. So I also want to thank you all for taking part, for staying here. Wishing you a good afternoon here at CSA, a nice time here in Lisbon, and thank you very much to Boston Scientific and all the speakers for taking part in this symposium. Thank you very much.